just because next week we have a lot to cover too, and we want to have time for review. So you guys just took your test in Dr. Horgan's class. When he starts talking about the hip, he's going to introduce you guys femoral acetabular labral tears and also femoral acetabular impingement. Okay, the hip has a labrum just like the shoulder, and it can be torn and it can be impinged just like the shoulder. Okay, just like the shoulder, the hip capsule plays a role in that. Okay, and it's usually the posterior part of the hip capsule that can drive that femoral head anterior and cause impingement and pain and labral tears in the front part of the hip. Okay? And again, we're going to touch on this again next week, and he'll address it in his lecture too. But I want to show you guys now, we want to try to find a way to stretch that posterior part of that hip capsule. Okay? So the goal in this one is to stretch the back part of the hip capsule. We're going to have the patient's leg in flexion. Okay? I'm going to try to distract his leg down. So as I distract the leg down, so here's his acetabulum, here's his femoral head, okay? As I distract his leg down, see how that's stretching the posterior part of the hip capsule? Okay? So I'm distracting it down, and there's a stretch on that posterior hip capsule there. Okay? First, we want to assess internal and external rotation like we talked to last week. Okay, so I put it in 90 degrees here, and I'm looking at his internal rotation compared to his external rotation. Okay? So it's less on this side. Do you see that? Okay. So, as I distract down, I'm also going to keep his leg in some internal rotation here too. Okay? So as I distract and internally rotate, it should be stretching that posterior hip capsule. In addition, he's going to actively flex his knee up to the chest. Okay? You can have it do it actively. Dr. Pierce does it passively. I think actively helps them get into the exercise more and puts a little bit more force in it, but you can get it passively too, and that makes a difference. So essentially what I want to do is provide a distractive force as close to the hip as I can, while the patient actively flexes his knee to the chest, okay? And really you got to get low on this one. So I usually have a towel in here, and I'm going to explain the procedure to the patient. I'm trying to stretch the back part of the hip here. I'm going to stretch this joint. When I say go, you're going to actively bring your knee to your chest. When I say relax, you're going to let it go. And I'm going to bring it back down here, and then you're going to actively bring your knee to your chest again. Okay? So I'll get down in here, I'll put the knee over the shoulder. Okay? I'm going to take my tissue slack, just like I would in a palpation procedure. I'm going to take it L to M to get it into medial rotation. Okay? So I'm going to go in here, L to M, so I have it in internal rotation. I'm going to have the patient grab the sides of the table or the top of the table. Why? Because I'm going to distract down. Okay? I don't want to slide him off the table. Okay? So I'm going to have him bring you to your chest. Go. And relax. Go. Relax. Go. And I'm just providing a straight traction down. Okay? Especially when he brings his knee to his chest. Go. I'm just stretching down. And I relax. Go. Good. So now he's starting to get out of internal rotation again, so I usually throw the leg over my shoulder a little bit more. Take another contact. Go. Come on. Go. Go. And I'll lighten up my pressure a little bit. If it's painful, I need to know if it's painful because of my contact on the rectus, or is it painful because it's stretching. If it's painful for my contact, I'll lighten up a little bit. If it's painful because it's stretching, too bad, so sad. Okay, then we reassess.
So that helps with internal and external rotation?
If I wanted to do external, I would do external. Would you guys see the difference? It's like a 5 to 10 degree difference, right?
Are you resisting his force, or are you resisting?
As he's actively bringing his leg up, I'm providing a constant resistance as close to the femoral head as I can. My pressure down acts as a fulcrum, okay? So if my pressure down is going down and his leg's going up, if this is his knee, it's pulling the hip down, posterior, right? And stretching that posterior down. No, I'm not. The old way, before they came up with this way, the old way of stretching the posterior hip capsule was doing this. Okay? Problem is, when you have impingement in the front, when you get into this position and push down, that's impinging it more. It hurts more, yeah. So now we just distract straight down. Okay? So that would be the posterior hip capsule mobilization. Anything else you want to cover there? Okay. Another way that I learned, we'll go over this quickly, this is really easy. Another way I learned that actively warms up patients and their glutes, and you want to help them, it helps stretch the capsule, and it also helps warm up their glutes. It's simply by bringing them into flexion and having them push me away. Push, relax. Push, relax. Push, relax. And I kind of work the arc. Push, push. And you can remind them, push here with the glutes, okay? Push. I don't want to go too far over here if it's painful. Okay? Push. Push. If they have knee pain because of a knee injury, I just put less knee flexion in it. Push. Push. Okay, and they can feel that start to warm up their glutes. It actively stretches their glutes. Every time I come up into here, it's getting an active stretch and helps them fire with their glutes more. And it also stretches out the capsule. Okay? Any questions with that?